Hello, everyone. My name is Mojtaba Shafiee. I'm a PhD student at the College of Pharmacy and Nutrition, University of Saskatchewan, and I'm working under the supervision of Professor Hassan Vatanpras. So one of the objectives of my PhD project was focused on exploring the implications of the COVID-19 pandemic on food security and coping strategies among urban Indigenous peoples living in Saskatchewan, Canada. So first of all, before moving to the presentation, I would like to acknowledge that I work and live in Treaty 6 territory and the homeland of the Métis. So first of all, I would like to start with the background. So the COVID-19 pandemic has had a significant impact on global health and the economy, leading to the implementation of measures such as lockdown, social distancing, travel restrictions, and so on. So these measures have disrupted several aspects of life, such as food security and food access. Vulnerable populations, such as urban Indigenous peoples, are particularly susceptible to the pandemic's negative impacts due to the pre-existing systemic differences. Why it is necessary to look into the immediate implications of the COVID-19 pandemic on food security of Indigenous peoples? Because of two main reasons. First of all, providing immediate assistance to this vulnerable population, and second, developing policies and programs that can help us to be better prepared for future economic or public health crisis. So we aim to examine the impact of COVID-19 and related lockdown measures on food security of Indigenous peoples. That's why we developed an online survey in collaboration with 10 Indigenous co-researchers. So from January 2021 to June 2021, so we developed this questionnaire, consisting of background information, food security questionnaire, a state of food access, and traditional food consumption. So regarding the food security, we use the household food security survey module that I think most of you are familiar with, 18-item USDA food security questionnaire. So in this questionnaire, we have questions ranging from worrying about running out of food, and also children going the whole day without food. So the food security server module unfortunately doesn't account for traditional food consumption and traditional food practices. So that's why we included 7 multiple choice and open-ended questions to understand participants' traditional food consumption habits. So the survey was distributed by SurveyMonkey from August 2021 to August 2022 for 1 year. So, and we received ethics approval from the Behavioral Research Ethics Board of the University of Saskatchewan. So we collected data from 130 participants, and as you can see, the mean age was 36 years, and we had 78% First Nations people, and then we had about 22% Métis, and we had 76% female and 22 male. And you can see other demographic information in this slide. Regarding the income, the marital status, the education level, renting, home ownership, and household size, and also employment level. So moving to the next slide. So this slide shows the prevalence of household food security during the first 4 months of the pandemic. So as you can see, more than 68% of urban Indigenous peoples living in Saskatchewan experience some level of food security, with more than 33% experiencing severe food insecurity. So we asked some questions. Regarding the state of food access. For example, we asked, did your household experience any challenges accessing food? And the first response was food price increase with 47%, and then limited food availability at food markets, and restricted access to food markets, restricted mobility to leave the home, and also loss of income due to the COVID-19 pandemic. The next question was regarding experiencing any challenges any food security challenges due to the COVID-19 pandemic. And as you can see here, 51% of the respondents mentioned that they were not able to eat the kinds of food they preferred, having to eat a limited variety of foods, having to eat some foods that they didn't really like, and not having enough food, and finally having to eat a smaller meal that they felt needed. And these open-ended questions focused on the coping strategies related to the food insecurity and access to food. So the first coping strategies by about 41% mentioned in the survey was community resources and government food distribution programs. The next one was changing eating habits, family and social network support, and budgeting and meal planning, gardening, seeking out for deals and sales, and relying on alternative protein sources and putting children first. So we asked some questions regarding traditional food consumption patterns. So as you can see, more than 53% of urban indigenous people reported that they don't eat any traditional foods, or they rarely eat traditional foods. So, and as you can see, 22% one time per week, and 20% 2 to 5 times per week. What is your traditional food preference? So, as you can see, more than 41% of the respondents reported that they preferred mostly store-bought foods and some traditional foods, and more than 20% reported only store-bought foods. So, but we had some, only traditional foods was 3%, mostly traditional foods and some store-bought foods 13%, and about the same amount, about 21%. So these are the most common traditional foods consumed by urban indigenous peoples. The first one was wild and game meat, such as moose, deer, elk, and so on. Fish, such as salmon. Wild plants and berries, breads and pastries, soups and stews, and fermented foods. So the next one, what factors prevent you from eating traditional foods? Again, no time to hunt, fish, forage, or prepare was the first, the most prevalent answer. No access or availability, lack of knowledge of how to cook it, prepare it, or access it. Don't have kinship ties with those who hunt, fish, or forage, and also expense to buy bullets and the equipment required. So what factors limited traditional food availability or accessibility? I would like to apologize for the error that I have in this slide. So the first one is that lack of access to the land, which is here in the last one. So to be exact, so lack of access to the land was the first answer with 54%. Lack of traditional knowledge to harvest and prepare was the second response, and then climate change affecting traditional food harvesting and consumption, the third response. Financial costs for acquiring traditional foods, and finally, geographic isolation by 10%. And the final question that we asked regarding traditional food consumption was, did your household experience any challenges accessing traditional foods due to the COVID-19 pandemic? And as you can see, about 42% responded yes, they faced some challenges accessing traditional food consumption. And this is the advantages. We asked about the advantages of traditional food consumption, and as you can see, health and nutritional benefits was the first advantage, with 65% of participants mentioned that. Cultural significance was the second benefit. Taste and enjoyment, affordability and accessibility, environmental sustainability, and finally, digestibility and shelf life, in their opinion, was the advantage. So regarding the concluding remarks, so during the first 4 months of the pandemic, more than 68% of indigenous peoples experienced some challenges, food security challenges, and with more than 33% experiencing severe food insecurity. The short-term effects of the COVID-19 pandemic exacerbated existing disparities and disproportionately affected urban Indigenous households. The finding of this study highlights an urgent need for interventions and policies that ensure access to culturally relevant food, especially in anticipation for future crises, because the COVID-19 pandemic is already over, but I hope that it was the final pandemic, but we know that we may have future economic and public health crises, so we need to be prepared. And future studies are needed to explore the impact of rising food costs that we are still experiencing and supply chain challenges on food security in post-pandemic era. And finally, I would like to acknowledge my supervisor, Professor Samatan Press, and also my committee members who helped me with this project and running this survey. And also, I would like to thank SK-NEIHR for supporting us with community partnership funding for this project. Thank you so much.
Hi, my name is Hailey Dunn. I am a PhD student at the University of Saskatchewan, and I am co-supervised by Dr. Stacey Lobo, who is also from the University of Saskatchewan and present with you guys today, and Dr. Chantal Johnson from the University of Sherbrooke. I'm really excited to be joining you virtually from Russell, Manitoba today, and to be able to share with you the preliminary findings from our community-directed needs assessment with the First Nations community in Northern Saskatchewan. So before we begin, I wanted to acknowledge the diverse lands that I live and work in, which are Treaties 2, 4, and 6 territories and homeland as a Métis. I would also like to share a little bit more about myself. I'm a physical therapist, a student, a wife, and will soon be a mom to our first baby. I've always loved working with children, whether as a dance coach, soccer coach, or as a behavioral therapist for children with autism. I am non-Indigenous, but as a Canadian citizen and a healthcare provider, I recognize my role as an ally to Indigenous people in Canada, and I'm working towards my own journey of reconciliation. So Pelican Narrows is a part of the Peter Ballantyne Cree Nation and located in northern Saskatchewan. As you can see from the map here, it is about a 6-hour drive from the city center of Saskatoon to get to Pelican Narrows. The population in the area is young and growing, as is much of the Indigenous population in Canada. The Pelican Narrows and Peter Ballantyne Cree Nation have worked with university partners on several collaborative research projects in the past, including a recent physical therapy tele-rehab clinic for adults with chronic back pain. Prior to the COVID pandemic, Elder Rose Dorian, pictured here, advised researchers that pediatric rehabilitation should be the next priority for collaboration. Throughout Canada, Indigenous children experience inequitable access to healthcare and thus poor health outcomes. Access to healthcare is compounded and complicated by several factors related to accessibility, availability, affordability, and acceptability of services, as well as the ability of services to accommodate to their users. There is an immense paucity in the research about the need for rehabilitation services for Indigenous children, as well as culturally responsive models of rehabilitation services for Indigenous children and families. So after the request from the community, our first objective was to do the community needs assessment, which would help us identify what families have experienced when trying to access rehab services in community, and what their needs and preferences are for rehab services going forward. The needs assessment also allowed us to continue to build upon existing relationships and develop new relationships with community members who are really critical pieces in promoting health for Indigenous children and families in the community. So we have utilized a community-based participatory action research framework, incorporating principles of two-eyed seeing and ethical space. We've used a questionnaire to learn about the descriptive demographics of 3 children in the community, and we have used semi-structured interviews to gather stories from 3 healthcare providers and 4 families in the community. Our aim is to collect data from at least 4 more families, but today I will share the preliminary findings that we have to date. And here pictured is myself and Ursula Roberts, Jordan's principal coordinator, who has been super amazing to collaborate with on this project. So the children in our sample range from 3 to 12 years old, with 2 of the children being diagnosed with autism spectrum disorder and 1 child diagnosed with cerebral palsy. As you can tell from the graph, the children had complex needs related to gross and fine motor skills, communication, including hearing and speech, vision, behavior, and ability to participate in activities of daily living. Yet none of the children were actively receiving regular rehabilitation services. 2 had received services in the past, and 1 was currently on a waiting list to receive services in a community that was over 4 hours away. So from the stories and experiences of the families and healthcare providers, we came up with 4 themes, which were overarched by themes of family, culture, and community, which provide a foundation for child well-being and are critical considerations for pediatric rehab models in the community. So the first theme described the stories about the current lack of any rehabilitation services in the community. In the past, we learned that rehab teams have traveled to Pelican Narrows, but the stories shared by the families and providers suggested that the visits were too infrequent and typically limited to only speech therapy. As well, the services, when they came, had such a short amount of time, and there was a need to see more children that could benefit from the services. We learned that there was obviously a large number of children who would benefit from a variety of services, including physical therapy, occupational therapy, speech and language therapy, and dentistry. As well, we learned from the families that they really wanted more therapy support and resources in the schools, and more education and knowledge about supporting children with developmental conditions and concerns. Participants highlighted the negative impacts of service disparities on families, which included poor child health outcomes, increased caregiver burden and stress, and poor emotional and spiritual health. One participant shared a story about how families in the summer would really be looking forward to participating in the fish derbies in the community, but would have to miss out on these if they had to travel outside of community for children's medical appointments. And then this would negatively impact emotion and spiritual well-being. The second theme described barriers to care that participants experience when accessing rehab services. Racism, intergenerational trauma, and fear were cited as barriers to care. It was also clear that there was a lack of understanding by urban healthcare providers on the realities of living in a rural and a remote community. And this created another barrier to accessing responsive care for children and families. The stories shared that the providers in urban centers really didn't understand what communities had access to, and this could further complicate the care. It was also found that travel was a barrier to care. As I mentioned earlier, it seems that the minimum amount of travel that families will do is 4 hours. And that's only if they go to a certain community. Often that time can be much, much longer and require stays overnight. So there was associated barriers with travel, which included having a reliable transportation, the cost of travel, such as fuel, accommodations, and food when you're on the road. There was also a lack of choice about which community you may have to travel to. So one caregiver shared that they would have loved to be able to go to Prince Albert, for example, where they had family that they could stay with, but that wasn't an option for them. They would have to travel to a different city instead, and they weren't given a choice. It was clear that travel also was stressful for families and children as it disrupted the routines, and there would be other family members who were left at home. And it was stressful for children who already may be sick and needing health care. The third theme described what families and healthcare providers are hoping for pediatric rehabilitation service models. They wanted services that are family-centered, so that would allow multiple members of the family to join, which is something that just isn't a reality when families have to travel. Usually only one member will get to go with children to the appointments, whereas the preference would be for as many family members as possible to join for treatment and to learn about what the child's needs are and how they can help. Families wanted care providers who are empathetic and who considered a variety of social determinants of health that influence the child's well-being and how care should be provided. It was suggested that the rehab service models going forward should be built on existing foundations, which included a really strong and motivated team of community health nurses in the community. Participants also described the importance of still having face-to-face sessions for children and relationship building if models going forward are using a hybrid approach with some virtual methods as well. Families wanted to ensure that if evaluation methods are utilized in rehab services, that these methods respect culture and ways of living and reflect what is important for Indigenous children's well-being and development. The last theme described the potential that virtual care models have for improving access to pediatric rehab services in the community. We discovered that there was an overwhelming willingness on parts of families and healthcare providers to try a model of care where families would utilize a remote presence robot to connect with rehab providers in urban centers. Some participants described challenges related to hesitation by the families, poor internet connection, and managing behaviors. Like, as you can see in this one quote, the family had tried using virtual care at one point, but the child was pretty distracted when trying to pay attention to the robot. However, all the families said that even if it might not be super perfect for their child, it would probably be beneficial for another child in the community. Overall, the participants described that it would be beneficial for families to be able to stay in the community and receive services. So the needs assessment emphasized the need for a community-directed pediatric hybrid rehab model that maximizes both community and family strength. We have two exciting upcoming projects to work together on fulfilling this need. The Mobilize project will allow us to work together to co-develop a culturally responsive pediatric health and development measure. And then we will work together to co-develop, implement, and evaluate the pilot hybrid pediatric physical therapy clinic, which will utilize a remote presence robot to connect children and families in the community with an off-site pediatric physical therapist. So thank you all for listening today, and I'd like to acknowledge our community partners, Elder Rose Dorian, who inspired the project, and the community of Pelican Narrows and Peter Valentine Cree Nation for welcoming us to the city and sharing their stories. Thank you.
All right, so my presentation is going to be a little bit of a different style, just because I'm at the beginning stages of my research. So instead, I'm going to talk about my community and what I'm doing. Before I get started, though, I do want to acknowledge that we are gathered here on Treaty 6 territory, and I live and work on Treaty 4 territory, and I benefit from the land every day. I also am a white settler, and I have unearned privilege because of that. So next things second, I'm very proud today to be presenting our project titled Promoting Healthy Living and Preventing Type 2 Diabetes, a community-led initiative with Cowessess First Nation. And I'm sure to say our project when I start discussing this project because it does not belong to me. Rather, it is the property of Cowessess First Nation, and I am a tool that the community is utilizing in their production of this project and this initiative. Here I have an outline for the presentation, and you will notice throughout my presentation that I have included pictures that aren't necessarily relevant to the presentation, but do sort of encapsulate who I am and what I see on Cowessess First Nation every day. So they kind of celebrate through my eyes and my lens as someone behind the camera all the time, what am I able to do. So when I first started with Cowessess, or when I did my undergraduate degree, I had no idea that I would have the opportunity to work for Cowessess First Nation. I grew up in Yorkton, Saskatchewan, which was about an hour drive, depending on how fast you go, from Cowessess First Nation. And I was so thrilled once I graduated to have the opportunity to work somewhere so close to home and somewhere that I had known about my entire life. I had gone to elementary and high school with Cowessess First Nation band members. It had always been somewhere on the map in my head, and I'm so very thankful that I get to work somewhere that I now get to call my home as well. So here in the pictures, on the left I have my youth cooking class from last year as we're outside doing an activity, as sometimes it's easier to teach after you've exercised a little bit. And then on the right I have my nutrition booth from one of the powwows on Cowessess. So if you don't know, Cowessess First Nation is a 39,000 hectare reserve located in the Quebec Valley. It is home to 846 on-reserve members. These on-reserve members are my family now. These are the people that I wake up every morning and I'm like, oh, I get to go to work today and I get to see Lyndon Leroy, or I get to see Kelly Fingus, or I get to see so many, Gil Leroy, like so many people that I wake up in the morning and I'm like, oh, these people are my family. And being someone whose family is far away, it's nice to have family so close and some that I get to celebrate every day. So here is a map of where Cowessess is. So it kind of just shows how far we are from major centers. And now when it comes to type 2 diabetes. So as many of us are aware, type 2 diabetes rates in Indigenous peoples are higher than ever seen before. This issue is not new, although the rates keep climbing. In 1999, the Aboriginal Diabetes Initiative was created. And this program funds dietitians, nurses, certified diabetes educators to work with First Nations to address the high rates of diabetes, but the rates are still growing. The rates of diabetes for Indigenous people living on reserve is 17.2%, and the cause for diabetes is vast and can be linked and related to the history of residential schools and the legacy of hunger that they have left. The impact of the residential schools is still seen in many communities, including the community of Cowessess First Nation. Currently, through the ADI program, the direction is not always led by the wants and needs of community. This is where our project of preventing type 2 diabetes, a community-led initiative with Cowessess First Nation, comes in. So instead of the direction coming from a background of colonization, the project is following the direction of Cowessess First Nation and acting on the wants and needs of the community members who are most affected by the change. And as the members of the community should always be allowed to choose their health care and how they want and express what their wants for health care and what their needs are. So the goal of the project in question is to help the community of Cowessess in developing an initiative that works for the community. And the research question then becomes, how does this community-led partner-based health promotion initiative on Cowessess First Nation impact the prevention and control of type 2 diabetes? In order to answer that question, a few things have to be done first, including gathering information on the health statistics for Cowessess First Nation, assessing and understanding what the current barriers and facilitators to care are and how they exist in the community, and what the health program and initiatives that the community wants and needs actually are. Finding the information for this background data will help us to answer the research question through the objectives. So for the steps of the project, the first one is assessing the current rates of type 2 diabetes, predisposing factors, comorbidities, and complications within Cowessess First Nation. Assessing the current best practices in diabetes prevention and support among Indigenous communities, as it is available in the literature through scoping review. And then the last step would be to conduct those focus groups with community members. So then it brings us to what has already been done. So there was a health needs assessment survey that was done in 2019 before the project actually began, that was done by the Cowessess First Nation Health Department. And this survey had 297 responses, but it covered all health metrics. So there were a few questions related to like diabetes and actual diabetes rates and complications that people were experiencing. So this past July, I completed a Cowessess health assessment survey where I went door to door to help reach, with the help of research assistant Chastity, pictured there, very beautiful in her headshot. And we went door to door to gather responses from community members. So we went to all 233 houses on Cowessess First Nation and collected 111 responses. Completing the survey was a wonderful experience because not only did I get to like check off something on my checklist, but also I was able to meet and communicate and showcase my passion for the community to at least 100 people, given that Chastity and I sometimes split up and would see alternate people. So it also allowed me to figure out and realize what the history of Cowessess and the culture is even deeper. And it also allowed me to create relationships and bonds with many more community members, which as a community dietitian, now my caseload has doubled, if not tripled, because the community members were able to meet me and see what I can offer for them and how willing I am to bend to their needs and wants to provide the services and care that they are looking for when it comes to their diabetes. So since, now we go into the next steps. So since data has been collected, the next steps is to clean and analyze the data. I'm very hopeful that this will be done soon so I can move on to that focus group side of things and just start talking to people again, as that is what I love to do. So data will be cleaned and analyzed according to those procedures and stuff. And then we fall into our recruitment plan for the focus group. So this is the poster that we will be showcasing for our recruitment plan. So this will be circulated on the social media pages as well as distributed to health workers to hand out to people. And I will also be doing that as well, just to give people the opportunity to come forth and showcase the struggles that they're having and what their care needs are when it comes to type 2 diabetes. Okay, so where can we go from here? So we can go forward to create and help. My goal for this project is to ultimately help Cowessess in the creation of a plan that works for them and is sustainable and self-sufficient for the community. And contrary to some other research that happens with Indigenous communities, I work for Cowessess First Nation. I go there every single day. I plan to go there every single day long after the research is completed. So I'm acting as a facilitator in the community for the foreseeable future to provide this opportunity and ensure that this program works and is reliable and sustainable for the community. So the legacy of hunger from residential schools, combined with the colonization of Indigenous food systems, has played a large role in the rising rates of type 2 diabetes in Indigenous people. And I know that this project will not fix all the wrongs of this time, nor is that my intention, but I do feel like it's one step in the right direction when it comes to that reconciliation. Sorry. So I would like to thank everyone who has been assisting me in this project, but before I finish, I would like to leave you all with a quote that I got from another diabetes prevention project from a community elder, and it goes, "It's not about lighting fires in other communities. It's the idea of bringing your fire to another community and sharing it and letting them understand this is how it worked for us, but just to use it as a guideline, and they can have it to do their own work over there. They can throw it out or leave it in, whatever they need to use pertaining to their culture, pertaining to their kind of people, whichever point they come from." And I feel like this is something I would like to instill with our research with Cowessess. I hope that it's something that other communities can look at and use when it comes to diabetes care. And I hope it is something that will work for Cowessess. And I know deep in my heart it will. And those rates will come down. And I will be out of a job in 30 years because type 2 diabetes doesn't exist for Cowessess First Nation anymore. And that's my goal. So thank you.
Hi everyone, I am truly happy to be virtually with you today. So my name is Rosalie, I am a physical therapist and currently a PhD candidate at Sherbrooke University and also under the supervision of Professor Lovo at the University of Saskatchewan. So today I'm going to share with you the result of a scoping review we conducted on the use of telehealth for pediatric rehabilitation needs of Indigenous children. I would like to start this presentation by acknowledging that the territory on which I live and where Sherbrooke University is located is the unceded traditional territory of the Abenaki people of the Wabanaki Confederacy. I am grateful for this opportunity to live on this land, which with such proximity to forests, rivers, and lakes, because this connection to land helps me every day to recenter myself. I would also like to share a little bit about myself. So, like I said, I am a physical therapist. I'm also a student. I am a sister to 4 siblings and a daughter to my living mother. I'm also a partner. I am non-Indigenous and a Canadian citizen. As a healthcare professional, I firmly believe that Indigenous health is a crucial issue that requires a holistic and respectful approach. My personal stance is that of an ally who recognizes the importance of Indigenous self-determination in health and strives to promote healthcare policies and practices that respect and strengthen the rights and dignity of Indigenous communities. A little bit of an introduction. So we know that Indigenous children are known to have poorer health and social outcomes than non-Indigenous children. This associated with insufficient and inadequate healthcare services, including rehabilitation services, plays a major role in maintaining health disparities. It is known that insufficient access or delayed services have detrimental effects on children's development and the quality of life of their families. On the other hand, high quality early intervention is known to positively influence cognitive, social, emotional, and motor development. Physiotherapists, occupational therapists, speech language pathologists are known to have an important role to play in such interventions because of their area of expertise covering all areas of development. Recent studies have also pointed toward telerehabilitation as having the potential to bridge the service gap by providing effective and acceptable rehabilitation services for children with multiple diagnoses. Telerehabilitation can enable rehabilitation professionals to interact with families and children in real time or not, allowing for the assessment, follow-up, interventions, and monitoring of conditions. Telerehabilitation can use various communication technologies such as phone, email, video conferencing. It can be delivered at home, in school settings, or in community centers without the need for families and professionals to travel. So this can significantly improve access to rehabilitation services and help to reduce the disparities in healthcare access that Indigenous children face. However, for telerehabilitation interventions to have a meaningful impact on Indigenous life, they must be anchored in Indigenous knowledge and vision of child development. And to this day, little is known about the use of telerehabilitation in this particular field. And this is what brings me to our research question. So what do we know about the use of telerehabilitation with Indigenous children and their families? This is our search strategies. I'm not going to spend too much time on the process. So we did an iterative process, conducted many searches, and consulted a lot of literature. We included a document after this full screening process. Our inclusion criteria were that documents had to discuss the use of telerehabilitation for Indigenous children and or their caregivers by PT and or OT and or SLPs. Extracted information were classified under different teams, as you can see here. For this presentation, I'm going to focus only on the first 3 ones. So of included articles, 3 aimed at exploring the use of telerehabilitation for Indigenous children, 4 others aimed at exploring tele-rehab for children and included Indigenous children in their sample. And there was 1 community-led needs assessment to inform culturally responsive rehabilitation services. We had various designs, so pilot studies, realist evaluation, 2 mixed methods. There was 1 qualitative study using Indigenous methodology, 2 qualitatives using Western methodologies, and one survey. Studies came from Canada, Australia, and New Zealand. So regarding characteristics of participants, as you can see here, L conditions. So there were various conditions identified amongst participants, but communication and speech and language difficulties was the one that with most occurrences. So most studies included both Indigenous and non-Indigenous participants. And in those studies, Indigenous children were frequently the minority of ethnicities, except for these two studies in which they represented the majority. There was only one study exclusively involving Indigenous children. Sorry, this one here. So studies focus sometimes on the perspective of Indigenous caregivers, if you can see here. And we also have 3 studies focusing on the perspective of rehabilitation professionals providing services to Indigenous children. I also want to highlight again the community needs assessment. So Indigenous children were not included as participants, but adults shared stories and perspectives relating to children and families. And the result of that study identified critical rehabilitation needs of Indigenous children in their community. How was telerehabilitation used? So video conference was used in all studies. There was also one mentioning that they used emails and virtual resources such as PDF and online gaming. 4 studies were conducted in a school setting. 3 used an hybrid model of care, which means that children are seen in person and through tele-rehab, like we explained earlier. And there was one key ingredient that I wanted to share with you, and that was the presence of a local support in the form of an Indigenous liaison officer or school staff. And it was said that having a person in presence with the child could help to coordinate appointments, moderate technological problems, or complete outcome measures. And it was also described as having the potential to build local capacities. We were also interested in how studies took into account culture. So we looked at cultural consideration pertaining to the research process and the intervention. So first of all, it was surprising to see that only 2 studies modified how they conducted the research. And there was only one that adapted so the one here, they adapted their data collection. But the one that I talked a bit earlier about, so the one by Reichert and all, there was a completely community-led project. Then it is also worth mentioning that the study at the bottom by Ashtemichuk, so it was not a research project, but rather a project developed at the University of Manitoba by partners of the university and Inuit communities in Nunavut to answer their specific needs. So they did not follow a research process, and this is why it's marked as not applicable. However, they co-created their interventions with communities, they offered training to professionals, and they completely shaped their intervention to be culturally responsive. Apart from that study, there was only the study by Graham and colleagues that mentioned that professionals did receive some kind of training, but few information were provided. However, I have to mention that the need for professionals to receive cultural training was a recommendation of most studies. We also wanted to see how interventions were modified to be culturally responsive to Indigenous children. The 2 studies who took this into account mentioned that they used a different approach to set up goals, that they opted for a strength-based approach, they prioritized relationship building, and used, with caution, standardized assessment. So this scoping review allowed us to map the current knowledge on pediatric rehabilitation used with Indigenous children. The 8 included articles highlight the paucity of evidence on the subject and show that telerehabilitation for Indigenous children is still under research. Our results show that in most cases, researchers chose to work in developing interventions for Indigenous children without collaborative development and planning with Indigenous communities. So how to move forward? So we still know that telerehabilitation is an important tool to support equal access to rehabilitation services for children. But to promote end-user technology adoption, community-led projects are crucial. Conducting research from an ethical space will ensure the decolonization of research. I would like to thank my co-workers, so Hailey, Wendy, Mark, Chantal Camden, and Stacey Lobo for their help on this scoping, and also the SK-NEIHR and the Revitalization for their financial support. And I would be more than happy to answer questions maybe later. Thank you, everyone.
Dansigidawa, Charlotte Ross Stigason, Muniao Sagaigan Otsigagi Piopigian. So my name is Charlotte Ross, and I was raised literally all around the lake at Montreal Lake. I don't know if anybody here knows where Montreal Lake is. Fish Derby, March, come win a truck. It's a long lake. And where we first grew up was actually in Molinosa, Timber Bay, and back and forth between all those communities. So that's just part of, oops, where do I point this thing? Okay, there you go. That's part of who I am and where I'm from. So kiwit no ko tsigagi piopigian, sao nok magai wigianigwa. So I live in the south. I live about an hour west of here in Rosetown. And when I was first moving out to Rosetown, a lot of my colleagues here at the university, because I worked at the university and I got out on good behavior. I was at the U of S for like 100 years. And, when I left, I was moving out to a small rural town. The capital of redneck Saskatchewan is where I was moving to. Rosetown doesn't have a very good reputation because we played hockey there with their kids as well. And Phyllis is here in the room, and she can vouch for me, or almost getting into fights with the other parents. I'm just kidding. Phyllis and I weren't like that at all. But it was pretty trying to go to a small town. But I knew that they needed help as well. And we just packed up and moved out to Rosetown. And so my son has graduated from, we started doing the TRC calls to action before the report was done, before all of the recommendations were done. And so it's been a really good experience for us to be out of our comfort zone and in a totally different place. In a place where you lose something downtown and somebody comes and puts it in your mailbox, because we don't have home delivery, you just have a mailbox place where you go to the post office. So I called the guy up, Stan, he's our health store guy. I said, Stan, how did you know where to find me? He goes, oh, come on, Charlotte. He said, you're the only Indian in town. He said, of course we know where to find you. I was like, okay, thank you. So the land and territory, the acknowledgement here, I just want to acknowledge and be grateful to Kehteyag, so to the old people, to our elders, for the land here. And I was doing a presentation just a couple nights ago in Elrose for OTC, so I do some work for the Speakers Bureau. And so I showed them how to do an act of reconciliation. I said, it's not called Saskatchewan. Come on, let's restart you all over. It's called Kisiskatchewanik. And they were like, could we just stay with Saskatchewan? So Kisiskatchewanik, the place of the fast-flowing rivers, that's really where we are. It's home to many First Nations and to the Métis Nation who've lived here for many, many years before we came here. Gigawi Nawaski. So Gigawi Nawaski is our mother, the earth as well. And I was sitting back here realizing you can't really see these, but maybe they'll be available afterwards. But these are all the languages across Canada. The one language that we're focusing on is this one here, so the language families. So the Algonquin languages, and Cree is part of that. Cree is one of the largest, we have the largest number of speakers across the country. But that's not to say that we're safe. We're definitely not in the safe zone. I'm doing my PhD, and I did see my supervisor yesterday. She's like, I see you're in a program somewhere and it has nothing to do with your PhD. I'm like, yeah, I know. I said, I'm kind of putting, the cart way before the horse, because this is the area that I'm working in already. And my PhD is totally something different, but still the same. There's an overlap. So this is our map of Saskatchewan and all the languages we have here. So we're really, really rich. we're rich in language, we're rich in culture. I thought I'd throw this little map in here. Ispigawan Sinyan, when I get lost, and at lunchtime they asked, who are you? And I was like, yeah, that's who I am. It says University of Victoria and Montreal Lake Cree Nation. So this is my territory. Those are the roads that I know inside out and backwards. I could probably drive them with my eyes closed because they're all around, Malnosa, Timber Bay, Weaquin, Larange. Our trap line is just south of Larange. And so when we're coming together as community people, it was really around mental health crises, really around those things that were impacting our lives. And before I go ahead, I just wanted to thank and acknowledge my parents, for gifting us, for sharing that language with us. The Gaskitayag, Giapitsta, Denihidawiak. The team members that sort of came together and put this proposal together, community partnership grant to Sligatio. And I thought, what picture can I have of us? That really is us. On the best of days, we're like flying in the air, wondering, what are we doing? How did we get here? So Dr. Winona Wheeler is our leader. And she said, I can't be here today because I'm teaching classes all day. So you're going to go and do the presentation. I was like, okay, sure, because I'm already in Saskatoon. And then Gloria Lee, and then Lillian Sanderson. So there's a few of us that first came together and said, there's an issue, there's something that we have to do regarding this. And then from there, we decided to really start to explore. And I like this first picture. It's our equine therapy. So we're using land-based equine therapy and traditional medicine keepers. And as I was, mulling around and thinking, what's the title? It's going to be, we're going to do some research on, does anybody know Dr. Dolittle, the movie Dr. Dolittle? Well, this is the Cree Dr. Dolittle. So and I teach Cree as well. I've always been involved in my language. So we have an online adult group Sundays from 9 to 10:30. We've been meeting for about 2.5 years. And so, we're going through some of the words. And as we're growing up, you would hear these words. So when you're sitting with elders and they're visiting back and forth, and you would hear ka, ka, different variations of ka. So it's like, okay, well, the elders are talking Cree. I know they're talking Cree, and they're basically acknowledging what the other person has said, but they don't have to repeat everything they've said. And then I thought, well, where else do I hear that? When you go outside and you're seeing the birds, well, the crows are talking Cree too, because they're like, ka, ka. They're talking Cree to each other. And then I thought, the other one that we were coming across, like just doing syllables in Cree, was nay. So who says nay? Well, he's a picture of him right there. I'm not a very good nayer, but there's our horse going nay. So the other part is nay, and then the other one is guinea pig. So as the guinea pig goes around, and it's a snake, the snake is saying sss. As he's going around, and that's one of our sounds in Cree as well. The other one was the owl, so ooh, so ooh, ooh. And the other one is cows. So cows, when you're down here, you hear them, and they're actually talking Cree to each other. They're saying moo, moo. So all of the symbols and all the sounds in Cree are actually out here already, but we just don't pay attention to them. The other one I heard of was the chickadee. So the chickadee says chickadee dee 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 dee. So he's already saying in Cree dee dee dee. So we have to learn the pronunciation of our language. So in this project that we have, we're pulling people together. Language, land, and ceremony. Those are the three things that we're bringing into our project and talking about as a group. The other is, Cree. It just happened to be, I guess we're all Cree-centric because we're all Cree, and we're all sort of bringing other Cree people together that we know, that speak the language, practice the culture and the history. And again, there's a gap, so we don't see it being written about very much. Maybe we're in the wrong book, maybe we're not in the bookstore together. But taking a look at how can we support mental health? How can we support those pieces? This is a picture of Gladys, Elder Gladys Wapas, gray eyes. She's my traditional mom. So we're looking at this issue through the lens of historical strength and cultural resilience, and really looking at ceremony, because everything started off with ceremony. So when we first started, looking at this topic or thinking about it, we weren't even thinking about research. We were just thinking of coming together in ceremony. So we had a feast, we had a pipe ceremony, and Gladys, Elder Gladys Wapas, and also Mary Lee, Elder Mary Lee, those were the two that we went to ask for help in terms of how to do this. And so then it just evolved from there. So we have ceremonies included, storytelling as well. We have some research questions, what are the experiences of our practitioners in land-based equine therapy and traditional medicine in supporting mental health, and how are Indigenous languages reflected in that work? What are some of the barriers in carrying out their work? And do they think there's an intersection between the three to support mental health for Indigenous communities? We believe that the findings will be important to not only Indigenous communities, but also to levels of government and also to ourselves personally. We don't get involved in research for really any other reason, but to try to help inform what we're doing and try to make it a better place. So with that, we thank you for allowing us to be here, to be part of your day, and I'll turn it back to our esteemed MC.
I'm from northern Saskatchewan. I'm one of the presenters later on today. But society has gotten people in the north believing that we have a food scarcity problem, and we don't. We actually live, to coin a biblical term, the Garden of Eden in the north. We have food, we have meat, we have berries, we have it all, but we've stopped teaching how to use it. So I really appreciate those questions. And when you talk, a lot of what the panelists talked about also reflect on it, because when you talk about the loss of language, the loss of culture, that impacts all those things. And when lady spoke of diabetes, well, if you don't eat healthy, then you're going to get these strange illnesses and things like that. So, and then of course Charlotte, a lady I've known all my life, or most of my life. So the importance of combining the research, it isn't the silo research, it's all of it put together, because our communities don't need just one thing. They needed information and pieces of everything, and that might be an interesting research project in the future, is how do communities combine all of this, and how do we get help to do that? So those are just comments.
So now this one is working. Okay, yeah, thank you so much for your comment. So I have another objective. Another objective for my PhD project is looking into facilitators and barriers of healthy eating among urban and Indigenous peoples living in Saskatchewan. So, and I've had a couple of interviews with urban Indigenous peoples living in major cities, Saskatoon, Regina, Prince Albert. So, and all of them mentioned that lack of knowledge, and loss of that intergenerational transfer of knowledge, and they were, those of the participants that had children, they were really concerned about transferring their knowledge to their children, because they are, especially for those who are living in urban areas. So, and they were really concerned that we need to transfer this knowledge, because and some of the younger participants, they even didn't know. I remember one time I had an interview with a Métis, who was, I think maybe younger than me. So I was asking about traditional foods, and And then he told me, do you mean pizza? So, no, pizza is not a traditional food. So, I mean, this loss of knowledge and loss of connection to the land, and those are all important things to consider. So, and I'm keep learning about these issues that indigenous peoples, especially those who are living in urban areas, are experiencing. And I agree that we need to come up with a comprehensive kind of solution, and to see, because I know there are some limitations for those who are living in urban areas, and there are some limitations for those who are living on reserve. So we need to come up with something, and we need to do it fast, because as Marisa mentioned, there are there's the prevalence of obesity, diabetes, and other non-communicable diseases are rising, and food is one of the major aspects and one of the major points of intervention that we can do something for that. So thank you so much for your comment again.
Good afternoon, everyone. First of all, I'd like to acknowledge the Katayak who are here today, as well as all the knowledge keepers who are academic and otherwise who are in the room. My name is Erica Bowden. I'm the Chief of Cowessess First Nation, and I would like to acknowledge our community members as well as Marisa for doing a really good job and the work that you're doing in our community, so thank you very much. My question actually is for Charlotte, though. I just wanted her just to have that dread in her stomach. No, I'm just kidding. Of course I wouldn't. For Charlotte, I'm very interested, and especially because our community is actually very much prioritizing cultural revitalization through language. And I'd like to speak with you and Dr. Wheeler more afterward this. But in your research, I'm wondering if you are also studying the spectrum of gender as well as on and off reserve in relation to your study. Thank you.
I told Marisa, I said, I'll defer to her. She said, you better not. But yeah, I just really, when we start thinking about our research or, what questions we have to ask, we're sort of at the unknown stage right now. So at this point, we're really open to, what aspects should we include, what are all those things. So our first scheduled meeting is on November 4th on Saturday. It's a Saturday up in PA at the PA campus. And, just bringing our practitioners together. So we have 2 Cree equine therapists or equine therapy groups, organizations, and then 2, if not 3, land-based and traditional medicine, groups or individuals. And so bringing them together to ask them those questions, what are some of the activities you're doing? What are some of the effects that you see happening? And then taking it from there, back out again. So once we have, some basic questions answered, and then taking it through another filter, because it's like taking it and filtering it and sort of putting it through. I don't know if anybody's ever made anything, but when you make something, you have one big batch, and then you make it down and you make it smaller and smaller. So that's kind of the research method that I think we are going to be using, because we haven't really brought all of those things together before. Usually it's just 2 of them, but we've got 3 plus language that's going through all of that. So seeing, how is language reflected in land-based education, the Cree language, because that's the language we speak, and how is language reflected also in equine therapy? What are all those terms that the Gihteag that they used? Because it would be one term or a phrase, but the etymology, like taking that word and seeing how Wakotuin is in the language as well. So we have words or phrases, but they're already pre-built with meaning. And so it's just taking the words and seeing how the language is related to each other, and how horses, and I think somebody mentioned dogs earlier on today, And I was looking at our title, and so we were thinking of including dogs as well. And I was like, okay, guys, we have to like start and finish. This can't be a research project that goes for 10 years. We're all going to be really old by then. I said, we have a research project here, so we'll start with these pieces, and then we'll move it out, and then incorporate any questions that people have. So for sure.